Lindbergh said, yes, I'm a rheumatologist, but I do a few other things. Immunology, rheumatology. I used to run a place called the Diagnostic Center here, which is where we would see children with medical mysteries, I guess is the way to phrase that. So people who had symptoms, but no obvious explanation. So I spent a lot of time trying to figure out what's wrong with these children and how we can fix it, even if we couldn't figure out what was wrong. And so I have, I guess, some experience, therefore, in a lot of unusual illnesses and diseases. And this morning, is it still morning? I will, and feel free, interrupt me, ask questions, say, hey, Dr. White, what about this? What can you do about here? So I thought I'd talk first a little bit about connective tissue disease just in general. In particular, some misconceptions, actually, about, I think, what connective tissue diseases are. And then how we see it, how we diagnose it, what we can do for it. And then I'd like to actually dive into an unusual disease that we see a lot of it's just interesting. Okay, so let's see. Connective tissue diseases. Really, I think most people think of them as problems with anything that connects one tissue to the other. And there's a lot of things that do that. There's muscles, tendons, ligaments, bones, joints, right? It's all one package. But really, the way we think of it is in two broad categories. The first is defects or problems with some part of your connective tissue, and that usually ends up being collagen or fibers that are similar to collagen, elastin or fibrillin. And basically, these are the building blocks of your tendons. It's basically what it is, but really your skin, sometimes parts of your muscles. And Ehlers-Danlos syndrome, or EDS, is kind of the prototypic diseases of that genre. And what we focus on a lot of, or what we think a lot about, is the so-called Ehlers-Danlos syndrome type 3, also known as benign hypermobility syndrome. So if you have collagen problems, you can imagine that you might expect some stretchiness of some of your tissues, and the classic Ehlers-Danlos syndrome patients do have stretchy skin. So you'll see some pictures of the internet on them where they could pull their cheeks out, or the skin on their neck to about here. It goes back down, out here, comes right back down. So their skin is very flexible. Some people say loose. One of the terms, I'm not sure you spoke about this, but one of the ways we like to try to get a physical exam finding of this is if you put your hand flat, you can pinch the skin on your palm. And that doesn't happen to most people. You can't do that. But if you have some of the Ehlers-Danlos skin patient, you can get a good inch of skin up from your palm. Now, I would also like to say that's Ehlers-Danlos syndrome, the common type. We call that type 3. There are at least 12 different types of Ehlers-Danlos syndromes, and they involve different types, most of them, with mutations in collagen. So there's collagen 1, there's collagen 2, there's collagen 3. There are all these different types of collagen, and if you have a problem with one of those collagen, like for example, if you have a problem with collagen 4, that could be Ehlers-Danlos syndrome type 5. So you would like them to line up perfectly, but of course we don't do that. It's not logical. The thing about Ehlers-Danlos syndrome type 3, it's the most common, but we haven't found a mutation for that one yet. We haven't figured out what specific type of collagen is the problem. We do know how to diagnose it clinically. They tend, as you guys probably talked about, hyperextensible elbows, which I don't have, hyperextensible knees, which I have, but not because of collagen, but because of injured issues in tendons and ligaments. Palms flat on the floor, pinkies and fingers back 90 degrees. These sorts of maneuvers that most of us don't have, but some people do. I feel like I'm too echoey over here. Maybe this side's better. It's a light bulb. That's not a microphone. It's a light bulb. And so a common problem that we see in rheumatology clinic is people who have these symptoms. They're too flexible. Now, what's wrong with being too flexible? It's a little bit like having a door on hinges that are loose. You open and close the door over and over again, you're going to chip away at the edges of the door frame, and that's going to injure it. It's going to cause little nicks. They may not show up on MRI, they may not show up on imaging of any sort, but it will present with pain. So people who are very flexible or overly flexible often have pain because, if you want to think about it, their hinges are loose. And so even the process of walking, if they hyperextend, and I'm exaggerating the movements here, but if I'm hyperextending and using things, my joints are going to hurt. And so the classic person who is hyperflexible from any cause is that with activity, with more activity, they get sore afterwards. And it's not that the muscles are sore, it's that their joints themselves are sore. So, a 10-year-old girl who plays soccer, the following day, she doesn't want to get up out of bed the next morning. Her joints hurt, her knees hurt, and it's the ones that you're using a lot. They never say that their thumbs or fingers hurt after soccer practice, but they might after a long essay that they had to write at school, or a lot of typing, or too much Legend of Zelda. So we see probably 3 or 4 patients a day like this. They're flexible, and you can tell, you can examine them. You put them on a table and you hyperextend their knee up, and it just goes too far. And it almost gives people the willies when you just show how far these joints can stretch. The kids often say, well, what can I do to fix this? The kids themselves will say this. And there are a number of things we talk about. We talk about, some of it's counterintuitive. Number one, we tell them to avoid stretching. Which makes perfect sense if you think that the problem is their joints are too loose. You're not going to want to make them even looser by stretching. That usually gets us into trouble with the school PE teachers, with the, their sports teachers. Some of them are, they participate in gymnastics because they are so flexible. They're kind of natural-made gymnasts. But the more they stretch, the looser these joints will be, the more they'll have chronic aches and pains. And sometimes it's more than just an ache and pain. It will be swollen joints. Bad enough that they will then have to step away from some of their activities. So, counterintuitive, don't stretch. What should they do? They should strengthen. The other thing they should probably do is age, because I think, as we all age, we get less and less flexible. So I tell them, in another 50 years, you're going to be in good shape. I can't wait that long, Dr. White. I've got all these other things I want to do. Like, all right, in that case, you need to, work on strengthening, because if you've ever seen a bodybuilder, they walk around like this. They can't put their arms down because the process of strengthening their muscles leads to shorter, tighter muscles. So they're held tight. The more you strengthen, the tighter these things will get. Shorten up the muscle fibers and do that. Now, a good bodybuilder, of course, will stretch as much as possible to try to keep them, but we're not aiming for bodybuilding in kids here. We're just aiming for improvement in their muscle strength.
Dr. Wade, can I stop you there?
Please do, Dr. Lindbergh. Yes.
So what you're saying is don't restrict your activities, but rather have a therapist, for example, help you to strengthen, or
how do I make this happen? Yeah, so we start usually with some therapy, because what often happens, especially in kids, is they do it the wrong way. Get stronger. Okay, Dr. White, I'll just go get a 10-pound dumbbell and I'll start lifting. And the first thing a kid will do is they'll put the dumbbell over the leg and they'll stretch that elbow out with an extra 10 pounds. And so they're not doing what we want them to do. So we have limited range therapy to work on the strengthening. If you're going to do a curl, you don't go all the way to 180, definitely not past 180. You stop it 10 degrees short. So you're really just kind of working on mid-level strength, because you really want to avoid extra stretch with weights, because that'll make it worse for sure.
Dr. White, would that be the same type of therapy for an adult who has EDS?
Yes, same thing. If you get into trouble because your joints are too limber and too flexible, avoid stretching and work on strengthening. Those are very sort of the two key pieces. And we'll refer somebody to physical therapy with those explicit instructions. We have to call the coaches of the football team, if they have it, and say, the first thing you do for the first 15 minutes of football practice is stretch. Stretch. That's going to cause more trouble. A couple of other things we do is we have a variety of devices to supply additional support to any particular joint. Like if a child was having one knee that was much more flexible than the other, then we would add support brace that will help limit the hyperextension. Same basic principle.
Is that common to have a differential in the way your joints are affected?
I think it is. I haven't seen data about that, but just in clinic and looking at people, they tend to have one side. It may be because they're right-handed, left-handed, right-legged, left-legged, but there is more flexibility on one side usually compared to the other. And I think it's the non-dominant side. So the stronger right arm usually is a little less than the less strong left arm. So, who put that there? See, absent-minded professor, that's what's happening here. Now, we do see a lot of patients with other types of Ehlers-Danlos syndrome or Marfan syndrome or, well, there are a number of them. And those are a little trickier because the collagen there is much more fragile than in the standard EDS type 3. If you can actually injure or overdo things by working on strength. And I'll give you an example of how worried it makes us. So, the skin can be stretchy in people with Ehlers-Danlos syndrome. If they pull it too far or if you get a cut, it doesn't heal properly. You get these so-called fish mouth scars or paper cigar scars. It just doesn't heal up right. So if you pull something too far, you may not heal it correctly. So that's the skin. But people with Ehlers-Danlos syndrome type 4 often have problems with their aorta. Their ascending aorta can stretch, and you want your aorta not to be stretched for a variety of reasons. And so if you have a dilated aortic root from your Ehlers-Danlos syndrome, you are going to be asked to modify how much you exercise. And that gets a little counterintuitive, but you don't want your heart overworking because then your blood pressure will go up and you might stretch that aorta too much and it won't heal back up. Sir?
Can you have multiple types of EDS?
Can you? It would be unusual. There's a certain philosophy in medicine is that usually if you have one single explanation for your medical problems, that makes the most sense. Right? That's called Occam's razor. If a single explanation can explain all of your symptoms, that's probably right. But then there's a corollary or the opposite of that called Hickham's dictum, which is a patient can have as many diseases as they damn well please. Right? So, yes, but each one being relatively rare, the odds of one person having two things are less common.
Well, I think the reason because he was diagnosed with EDS, but I believe it was the hypermobility one. But then they sent him, he saw Dr. Willing.
Yes.
And she diagnosed him with 7, so they sent him in for, was it EE, where they do
probably echocardiogram, yeah.
And he has an enlarged aortic valve as well. So can that go hand in hand with hypermobility? So it's something we watch. You can't go in like every 6 months.
Right. It's a good question, and it's one of the problems with just kind of talking off the, what I should do is give you an hour-long presentation on every single different type of Ehlers-Danlos syndrome, but the reality is it would bore you all to death, and probably us, but one of the common features of most of the Ehlers-Danlos syndromes is that you're hyperflexible. So the first step is if you're very flexible, and you're being evaluated by Dr. Willing or somebody else, they're going to try to sort out, is this type 1, type 2, type 3, type 4? Is it the vascular type? Is it the type where you have the eyeball problems? Or is it just stretchy skin or just stretchy joints? Or a combination thereof? Or maybe it's Marfan syndrome. Is your palate high arched? Do you have other problems, right? So the first step is to really sort out which type. And that gets to one of Dr. Lindbrick's original question, how do you make the diagnosis? In particular, if there isn't a known genetic type. Right? So if I was worried about type type 4, which is a defect in collagen 3, which is present on chromosome 2. That's all true, I believe. We can tell the camera. I don't know. I feel like I'm, in trial. Yes, Your Honor. It's on chromosome 2. You can test for mutations in collagen 2 on chromosome 2. So, and you can't test for every type of mutation that's there, but in the very near future, probably within 3 or 4 years, we will be able to, do sequencing of everybody's DNA, and we can say, aha, you do have a problem in collagen 3, therefore you do have Ehlers-Danlos syndrome type 4. Like, we'll be able to prove that. The problem is in type 3, we don't know the mutation yet, so we don't know what it is. So, but part of Dr. Willing's workup or evaluation should have been to try to find the specific, and probably was, the specific genetic mutation to give you a firm diagnosis. That being said, depending on when you start,
He was like 6 or 7 was when
6 or
this
7?
started, and then he goes in for the ultrasound started.
Yes, yeah.
Like frequently, and then as he got older, they said it was starting to get down more to the size that he needs it to be.
Okay.
So he doesn't have to go in as often now, so it's like once a year, or whatever, and he still keeps an eye on
Right.
if he has any problems.
Good job keeping that aorta small.
So I didn't know if that was.
Right, so probably you have, there's several of them have vascular problems as well, so it's not just, but type 3, the so-called benign hypermobility syndrome or benign Ehlers-Danlos syndrome, is not supposed to have vascular problems. So, type 4, maybe?
I mean, do you think I should pop now? Because 12 years ago, when I guess he was diagnosed, would they not have?
They would not have had those tests, that's
so
correct.
Should we follow up with her maybe now?
I think it's always a good idea to see Dr. Willing again, yes.
Yeah, exactly.
Especially before she retires, which is probably within the next 2 years.
Oh, okay.
But yeah, I think it's a reasonable idea.
Okay.
And so probably you're being asked to modify your aerobic activity, right? Don't run marathons. Don't overexert yourself. Take it easy.
Yeah.
You don't hear that from a lot of doctors, right? You sit on the couch, play some more video games. You just don't hear that. Okay.
So can I ask a question?
Please.
So if the thought is EDS3, is there any, aside from clinical diagnosis, is there any other further workup that you will often employ? Or do you sort of, if somebody comes in, do you run through the spate of all the tests and then come to EDS3 as a process of exclusion?
Right, yeah, so we try to do a reasonable evaluation. I'm not going to sequence everybody's DNA off the bat, but we will look for skin fragility, the skin stretchiness. We will usually do an echocardiogram to look at the big vessel because of the importance of having that problem. We will often send them to an ophthalmologist to have the back of the eye examined to make sure there isn't some loose lens that you can see in Marfan syndrome. So we will do a reasonable evaluation, but we don't sequence everybody's DNA right off the bat. I think in 5 years, the standard is going to be, we'll swab your cheek, we'll sequence everybody's DNA, and we'll tell you exactly what this is. So maybe 5 or 6 years, I'll call it 6 years. So that's kind of what we do. And then it's what we call a diagnosis of exclusion. We don't think it's any of these other things, therefore it probably is Ehlers-Danlos syndrome type 3. Which is a little, disheartening to a lot of people, but there are a lot of diseases that are diagnosed that way.
So, new to the whole thing, and all the talk about LSD, is that connected with Chiari in some way?
Did you guys talk about that before, no?
Oh, I haven't.
Just really briefly, is that we are increasingly recognizing the relationship of hypermobility and Chiari, syringomyelia, spinal deformity. And I'm happy to hear your comments on this, but I think that while we're recognizing that association more and more, and neurosurgeons who care for people with Chiari and syringomyelia are increasingly aware of it, I don't think we have a great understanding at the the real basic level of why those two travel together, although that's an area of intense investigation in my world.
Right. So I guess the easy answer is maybe. Maybe. But one of the reasons we talk about the symptoms of the hypermobility and the strength, because that often causes a lot of problems for patients, right? That causes the majority of the complaints every single day. My legs hurt. Well, what is that from? Is that from something back here, or is it because there's an association between being too flexible? Again, we don't know, maybe, but it's our job to fix it. Try to make it better. So how do we do that? A little bit of relieving some of the flexibility and some of the stretchiness, but there may be some other symptoms and other considerations to think about. So let me switch gears a little. What do we have? A couple hours for this?
No,
Yeah.
I think we end at 12.
Okay.
So, I thought maybe I have a couple more questions.
Sure.
I'm happy to ask now or at the end, but,
Okay.
maybe.
Well, let me just cover two quick other topics just to sort of throw things out there for you. The first is there's a lot of other connective tissue diseases that probably don't apply here. Right? So the vast majority of what I think of as a connective tissue disease isn't a defect in collagen, it's where your immune system starts attacking different parts of your body. So the classic connective tissue disease is something called lupus. And I think probably a lot of people have heard of it. It's been on a lot of TV shows, but no one, even House, fully understands, what lupus really is. But it is not anything that really probably affects you guys. It's a problem with funny rashes and kidney disease and arthritis. So there's some joint aches and some joint pains, but it's usually not a subtle problem, and it's usually easy to diagnose. You just have to kind of think about it. So on that TV show, Dr. House is always thinking it, and he's saying, it's just not lupus. This patient does not have lupus. I think he says that every episode.
So since lupus is something that runs in my family, is that something?
Something to worry about?
Well, I have my mother, my sister, and my niece, all.
Right. So I think it's a reasonable thing to worry about. It does tend to run in families a little bit. It would mean that any particular person in your family, if it runs in families, has about a 10% chance of getting it. So that's pretty high, honestly. Is there anything you could do to prevent getting it? Probably not. Probably not. It's one of these things where your immune system just gets confused for whatever reason, either as a response to a virus or a bacterial infection or who knows what, and it starts attacking various parts of your body, including connective tissue. But the therapies are completely different. So if your immune system is the bad guy here, then we treat that by attacking the immune system. And none of those therapies will help Ehlers-Danlos syndrome. So connective tissue disease in some people's minds is, well, in everybody's mind, it's either a defect in the collagen itself or an autoimmune attack. Okay. One of the things, the other thing I want to talk about is an illness called Reflex Neurovascular dystrophy. It's a crazy little name. And what this is these are people who have pain and we can't tell why they have pain. And the reason I bring this up is because some of the therapies and tricks we use to treat that disease can be useful to help treat almost anybody with pain. And since pain is kind of a common theme of being human, especially as we age, it may be kind of useful. So reflex neurovascular dystrophy, it used to be called reflex sympathetic dystrophy. These are people who usually after trauma, so they hit their hand on the table, or their brother or sister does something to their hand, then it hurts, but then they kind of protect it because they don't want it to hurt anymore. And any touch to that kind of gets into this feedback loop where it hurts more and more and more. And so you'll see these children come in with their hand like in a funny position, and they say it's in a funny position because if they move it at all, it hurts tremendously. And they're guarding it and they're protecting it. Don't touch my hand, don't touch my hand. How bad does that hand hurt? oh, on a scale of 1 to 10, it's a 12. Kind of a common theme, you know, above and beyond. And then if you take a feather and you touch their hand with it, that'll send them, you know, through the roof. That's a 15, Dr. White, stop that! Okay? And we know that that feather isn't injuring the hand, right? It is not causing damage to any tissue, and yet that sensation is creating pain. So it's a very unusual disease. You probably see some a little bit here and there. Sometimes they come in, if it's in their leg, they'll have an epidural, like a chronic epidural, 6 months to try to treat the pain. So that represents a big problem for us, because you can look at the hand, you can MRI the hand, you can do any study you want, you can biopsy it. There's nothing intrinsically wrong here. What's wrong is the chemicals, the neurotransmitters that tell the brain that there's pain are revved up. They're just kind of out of control. So you might think, all right, well, let's just remove the neurotransmitters. I can't do the therapy for that yet. Why don't we give medicines that interfere with the neurotransmitters? Well, sometimes that works. We try some of these medicines. But I don't want to put a 5-year-old on a chronic neurotransmitter altering medicine for years. And so it turns out what does work is trying to break this feedback loop. Right? If a feather causes excruciating pain, something's wrong. Like the system, it's almost like your computer. If you hit the button too many times and it gets stuck and it just keeps opening up new pages, and the thing you have to do is shut your computer down and reboot it. So we try to do that with patients, and it's kind of an elaborate physical therapy regimen for how we do this with these patients. The first thing we do is we remove epidurals. We stop pain medicines, because the pain medicines don't work anyway. We put them on, you name it, and they're like, oh no, it takes the edge off a little bit, but it's still, now it's an 11 on a scale of 1 to 10, Dr. White. Okay, all right, well then I'm gonna stop your narcotics and we will do something else. And so if a feather hurts, we have to retrain the arm to recognize that it's just a feather, right? It's not injuring anything. So the first step is you take 100 feathers and rub their hand. Then you take fingers and you massage their hand. And then you gradually increase the stimulus to desensitize, if you will use that term. It's kind of it's not really accurate, but to sort of reteach the arm what normal sensation is like. They've been guarding it and protecting it for so long, they don't know what normal sensation is like. So feathers, massages, wire brushes, well, maybe not wire, maybe bristle brushes. And we give them some sophisticated exercises to work through. We will get a jar of pebbles and put some money down at the bottom and say, your job is to get that hand through those pebbles and get the coins out. So that sort of process then re-equilibrates their sensation so that they don't experience pain anymore. And they can be fixed completely. They'll come back 6 months later, oh yeah, totally fine, anyway, not a problem. Whereas before, just a feather did it. Dr. Limbrick.
What about the vascular component of that? They oftentimes will have hyperemic or kind of red extremities, right?
And that way, but they'll often, that's how it starts, but then it'll go the opposite way. It'll be cold and cool, partly because if you are experiencing pain, your normal physiologic response to that is to vasoconstrict. Your blood vessels clamp down. Imagine if you got cut with a knife, you want to minimize bleeding, your blood vessels will clamp down. And what clamping down does then is it prevents oxygen from getting to the tissues, and so it gets cold and cool, and in some cases creates more pain. Doesn't really create ischemia, at least that's kind of the philosophy. So that's more part of this loop. It just does this wrong. So warming it usually helps. And if a patient is severe enough when they come in and you do a bone scan of both sides, which is kind of a fancy radiologic test looking at the extremities, the affected arm will be cold and quiet compared to the non-affected arm. And that could be used as a diagnostic test for this. So one related problem with these patients is, one other thing you can do with these people is exercise them. So it's not just rubbing them and making them go through here, but if you put them on a treadmill and make them work to the point where they can't sort of keep up anymore, they'll get better as well. And there's some interesting corollaries. So they've taken these patients, but first we'll talk about normal healthy patients. And there's a device that inflicts pain. It's a thumb screw. Put your thumb in a thumb screw. Do you have these? Do you use these in the lab? You can put somebody in a thumb screw, and I could say, all right, well, there's 1 pound per square inch, 2 pounds per square inch, 3 pounds per square inch. Okay, that hurts. And we ask the subjects to tell us when it hurts. And in most healthy people, you get something like 7 or 8 pounds per square inch before it hurts. I'm making that number up. It could be ounces per square inch. I don't know the term, but 7, 8 per square inch, and it hurts. You could do this with somebody with reflex neurovascular dystrophy or fibromyalgia or any other kind of chronic pain syndrome. Put that in there, and at 2 or 3 pounds per square inch, it hurts. Now they say it hurts. Does it really hurt? If you put people in a functional MRI machine and do the same studies, you can see changes in the brain metabolism that would suggest they are indeed feeling pain at 7 to 8 pounds per square inch. What about the reflex neurovascular dystrophy patients? You put them in, you screw it down at 2, they say it hurts. Is their brain lighting up? It is lighting up. They're actually experiencing what you're experiencing at 8 pounds per square inch. Now you take all these people and you exercise them. You turn them into a marathon runner. Actually, the study they did was they looked at ballerinas. They made them do a lot of exercise, 3, 4, 5 hours of ballet every single day. And they were able to get up to 10 or 12 before they experienced pain, both here and on the imaging. So one of the things we do in our clinic where we have patients who have pain for whatever reason is we try to, in a sense, desensitize them, make them work their hands through pebbles, but we also try to turn them into ballerinas because their thermostat for what they perceive as pain or what they're actually experiencing as pain does change depending on what you are able to do. Now it gets tricky if your aorta is a problem. It gets tricky if you can't use your leg for whatever reason, but we tried anyway. Questions?
You mentioned something before about the, you would examine, I think you were talking about the PDS, and talking about the back of the eye. I know as an adolescent I had what was called iritis. Is that in any way? Because I was thinking maybe that would trigger the Chiari, because I never knew anything about the Chiari.
Right. No, I don't think that triggered the Chiari, so that I can answer fairly definitely, I think. So iritis is autoimmune. It's an attack of the iris.
Right.
The iris, the color part of the eye, it actually goes all the way around the back into the choroid. It's a fairly common autoimmune disease. It's probably related to your family's tendency to get lupus more than anything else, more than the Chiari, more than anything else. The most common cause of iritis in a child is we never know. We can't figure it out. The second most common cause is juvenile rheumatoid arthritis. And then there's a whole host of infections that can cause it as well. Cat scratch disease, toxoplasmosis. So there are a lot of things that can cause iritis per se. Usually treatable just with some eye drops, but sometimes you have to take stronger medicine.
Yeah. My question is from both the clinician's standpoint, but also I think the patient's standpoint, and that is that a lot of times people come to the neurosurgery clinic and they may have a Chiari malformation that is of a significance that a neurosurgeon may or may not offer surgery. And let's just say, for example, they're not offered surgery, and we think, okay, well, maybe there is an element of hypermobility. Can you talk about the role of genetics and rheumatology, pain medicine, and anything else short of surgery that might be helpful for them?
Yes, I guess I can try. Kind of a big topic. Yeah, I think the first step is to try to get a firm diagnosis, to evaluate and figure out exactly what this is. Is it an isolated Chiari? Do you have a syndrome? Is it part of Ehlers-Danlos or Marfan's? And so the first step is a good physical exam and probably a good evaluation, and in a few years, or maybe even now with Dr. Williams' help, a genetic evaluation. That will help us know what we're dealing with, because the next step in knowing the problem with the exact genetic problem or any diagnosis is tailored therapy. And if we know you have a problem with X, then what do we do to try to fix that problem? So first step, a good solid evaluation to make sure we know what it is. A little bit of a tricky question. What do we do before or instead of surgery? How do we approach that? I always, as I know you do, like to try to do the easier things for patients that hopefully can fix them rather than go straight to surgery per se. Some of the surgeries I know for you are easy. You can probably do them blindfolded.
Don't let that out.
Sorry, did I say that? Right, it's simple, behind your back, piece of cake. But we try to do the therapy, the interventions that we know work for some people. But honestly, it's a little tricky, because if you try to, it could take 6 months or years before you build up the strength that's necessary to counteract your overstretchiness. And so it has to be kind of a routine. I try to get the patients to really kind of commit mentally to the process that's necessary. I say, if there's a 12-year-old, I say, look, this is great. We're gonna get you in shape. I want you to go to the mall, go get some new exercise clothes, go shop and get some tennis shoes. You're gonna subscribe to some weightlifting magazines. You're gonna get Runner's World. This needs to be a commitment if you're gonna do these sorts of things. And they usually go to the mall. I'm not sure they get new running shoes, and most of them don't subscribe to the running magazines. But if I can get a few to kind of get their muscles, tendons, and ligaments in better shape, that helps, and then maybe we can delay or avoid the need for surgery.
Chiari.
Yes.
Is that something you just have to live with from now on? There is no relief.
I think that's for you.
Yeah, no, I think, it just depends on the person and the severity of their Chiari, and whether they need surgery or not. I think that can help us to understand how we might expect people to do after surgery, and maybe with some of the different measures that Dr. White is talking about. I think that's such an individual question that I think it's going to be hard to address. And as a surgeon, we're sort of dealing with this question all the time.
Okay.
And to me, it's always, as a surgeon, trying to choose the person that you feel like may benefit from surgery, and sometimes that's challenging. That's probably the hardest part of our job, is to try to understand who's going to do well in surgery. And as you know from what Kathy was saying earlier, the exact criteria for Chiari are even in question in some level. And this group, CSF, is working to help figure that out. But there is some subjectivity in trying to assess any individual's case and whether they benefit from surgery or not. If you are somebody who benefits from surgery, then I think that the Chiari, once it's treated with surgery, you can have problems down the line related to that, of course. But if the Chiari is adequately treated and you're still having symptoms, the question is that at the point where we talk about therapy either before or even in the situation after surgery that helps to address some of the issues of hypermobility.
Right, because I think a very important point here is oftentimes when someone makes a diagnosis, Chiari, syringomyelia, whatever the diagnosis is, all the symptoms somebody has immediately become attributable to that.
Right.
but that may not be the real cause of those symptoms. And so I think we and patients are often tempted to look for that fix. Right? You know, if my right elbow hurts all the time, it's because of my Chiari. Well, maybe not. Right? Maybe it's because I'm doing too much golf. Right? I don't know, but you have to be a little cognizant of that and make sure you're attributing the right things to the right problems before you go intervening.
I've had like a decompression surgery, but it's just that the simpler things in life still, you know, being able to laugh, having a bad cough, or bending over to pick up a piece of paper, those things are still like, wow, that hurts. It's not like a common migraine, but it's just that pressure, just feel like that brain wants to just explode right out of your head. And it's just a little, 10, maybe 15 seconds or so of pain, but I thought that the pain would it subside a little after the.
You know, I think it's reasonable to suggest looking back at the Chiari to make sure it's adequately treated. You know, I think that's worth discussing, but also within the context of this larger discussion of other potential causes. Certainly some of the things that you're describing do sound potentially related to Chiari.
How common is it to not ever need to get the surgery?
So, you know, the thing we don't have a great handle on, and you guys are asking great questions and bumping up against what we really know is people who focus on Chiari and syringomyelia. And the answer to that is that, again, it's this balance of when do we operate versus when we, you know, not operate, and what we think is the best for any individual patient. But also, you know, we still have lots to learn about the natural history of Chiari, and you know, people oftentimes say you're born with it, and then it stays with you all your life. You know, there's certainly cases that I and others have seen where it gets better over time, and even can go away over time. On the other hand, sometimes, as I mentioned before, Dr. White was here, there are a number of people who don't even discover it because their symptoms sort of have a crescendo later, not later in life, you know, as you're old, but in kind of the early adulthood period, like I was mentioning before, 20s, 30s, 40s. And those people, for example, probably, you know, may have had a little bit of a Chiari, but it wasn't causing them any problems until later in life. So I think it's hard to answer that. You know, some of these questions, you know, I think you'd need to look at the MRI scan to answer and try to figure out, in your case, for example, not you, but in anyone's case, you know, whether their symptoms are tracking upward or tracking downward or stable, and then to try to understand the influence of outside factors, you know, EDS, for example, and how that may be looking at it. So that's about the longest-winded way of saying I'm not sure.
It's true, though. It's hard to say.
Okay. Well, I want to thank you for your time today.
Sorry, again.
You know what, actually, I really enjoyed kind of hearing you just kind of talk through things. I thought it was great. And I know we end here in about 5 minutes, and you know, I'm happy to take any other questions. You know, the one thing just to remind you is that Tim, kind of back towards the back of the room, he's really trying to help us nail down this, and we've done now almost 400 patients we've looked at the genome on.
Yeah.
And so I'm hoping to help sort out some of the issues you've been talking about here over the next few years, and maybe we can get some answers
Great.
Through this Chiari Research Genetics group. Again, thanks everybody. Yes, ma'am.
I'm sorry, I guess a question on both of you are still here. So with him having EDS and Chiari, like, would it make it more risky, I guess, if he ever does need to have this, or chooses to have the surgery because of the EDS, and maybe like someone back up, and you know, I mean, does that put more, should he put it off longer, even if he becomes more symptomatic, I guess is my question, because of the EDS? Does that make sense? Sorry.
I think I understand the answer to that. I mean, I can at least answer it. So the first thing is, what we were hearing a little bit earlier is that it's possible maybe that he has a mixed type or more than one type. And based on what Dr. White was saying, I think, depending if there is a second type of EDS, it may influence the way, the way it heals. I think that's possible. Would you agree with
So,
that?
yeah, maybe you have type 13. It hasn't been discovered
Right.
yet, right? Type 13. I will say in the more severe cases with the aorta, they hesitate to do surgery on the aorta because the stitches don't actually hold into the blood vessel. So they will not do an aorta replacement in some of these patients because the stitches don't hold in.
Would that kind of go with the same, then maybe with the brain, your like vessel dura and everything else up there, it might not stitch together right, or?
I would say, from my experience and from what I know of experience of others, the surgery itself is technically okay. The healing may have issues as we just described. What we do, what we are concerned about a little bit is sort of over time, if there's some influence on that joint between the head and the spine. And there are definitely cases where people needed to go on and have fusions or other procedures to stabilize that. And that could be because of the surgery itself kind of weakening the tissues that are helping to hold that joint together. Or it may just be that, EDS and hypermobility may speak to an inherent laxity or looseness of that joint that may predispose people to need additional procedures like a fusion or a revision. And I think that it's a highly individualized situation.
I actually had two things. One question was, what exactly is rheumatology? I was diagnosed with Chiari about 5 years ago, but I've noticed probably within the last year, like my joints they hurt. And I know it's not EDS, that we just rule that out. But I know like my joints, literally, they just hurt almost all the time. More so like when the weather changes, that type of thing. It could be arthritis, I don't know. I know that I had some testing done and my regular physician wanted me to see
A rheumatologist.
a rheumatologist.
Right.
I'm
Yeah.
almost sure that's what she said.
Right.
So that's.
That question I can answer. That I feel good. I can answer what a
I was
rheumatologist
gonna
is.
say that, but like, they hurt, like,
Sure.
sometimes it hurts like to bend my fingers or to clap, like if I'm in church or to walk or anything like that, where they just literally just
Right.
hurt.
Well, seeing a rheumatologist is probably a good idea. I can say that maybe I'm not biased, maybe I am biased, I am a rheumatologist. But they are people who study connective tissue, both of the loose kind and of the autoimmune kind. And the most common kind, I mentioned lupus before, and the most common kind is really rheumatoid arthritis.
Okay.
So these are people whose joints do hurt.
Okay.
And it's not just hurt, they're inflamed because the immune system is attacking them. So it's a reasonable idea to see a rheumatologist if your joints hurt.
And the second thing was, I just kind of wanted to encourage both of you guys, or I was sitting here listening, and I was just going to tell you that I was diagnosed with Chiari 5 years ago. It's been almost 5 years, and I'll be 45 next year. So later on in life, as Dr. Lundberg was saying, and I've not had the decompression surgery, and that's by choice. I've seen 2 neurosurgeons, and I have herniated disc, I have, it's hard for me to say, psoriasis.
Syringomyelitis.
Yeah, I have that as well. Scoliosis, degenerative disc disease, and I live with those every day. But that's a choice that I've made because of not wanting to. My herniated disc are in my neck, very close to where the tonsils are, for fusion surgery and things of that magnitude. At this point, they're saying no surgery. So that's just a choice that I've made. If I wanted to have surgery, I possibly could have it. It's just a personal decision as to what you all would want to do for yourself. So yes, there is no cure. The decompression surgery is just not the cure. It's just a temporary fix, it's temporary relief for you, but there is no cure for Chiari at this point in time. So it's just it's a personal decision as to how, as they say, your quality of life, what you want to do with it. In the last 5 years, I've just adapted my lifestyle to it.
Yeah.
I live a full life. I do use wisdom and there are things they tell you not to do and things you should do. And I take the medicines and I'm on opioids and all of those things. I do those things. But I live. I have children in college, a husband, I have my grandbaby, and that's what you do. It's just a personal choice as to how you want to do it. So it's, I just want to encourage you that you can live with Chiari, have a full life with it.
Well said.
About the
Well said.
medication though. Because I took myself off all medications. I'm one that don't like them in the first place. Being a psych major, I would know what they're about. But it seems that even when I was taking the medications and even now, it's still the same. There was you go from everything from the gabapentin to the tramadol and all that. And even when I was taking all medications, I still would feel the same as I feel without taking the medications. So there's no difference in changing.
Right, so I take them, it's reasonable.
Right.
Yeah, that's why with the analogy of these kids who medicines don't help, this is a thumb screw thing, turning you into a ballerina might help someone.
I cannot see that. So when you're talking about the cartilage and everything, I know my cartilage in my knees feel like gravel.
Yes.
And if you feel my knees, it's like walking on gravel. But isn't that just due to age? Could that just be due to age? Arthritis runs in my family as well, as we all have it in the hips, but
Part of the problem with being human and living on a planet with gravity is that, in fact, we do age faster than we want, and I have degenerative disc disease in my knees. I have no cartilage in my neck. I've got no cartilage in my left knee. I don't have a Chiari as far as I know, but I've never looked. But yeah, there are a lot of these other symptoms are attributable to other things that we just don't have good answers for.
I appreciate you guys very much because you've answered some questions that I needed answered I'm only new to the game since 2014, but I didn't know this thing existed, so thank you.
All right, thanks everybody for coming.